Very much. Let me share my slide now. I hope you can see the screen.
Yeah, perfect.
Okay, so first of all, I'd like to thank the AIOS for kindly inviting me. And Sonyu kindly helped me to choose the topic to speak on because he said, you all like to hear about zonules and the absence of zonules. And in particular, he told me not to talk about femto because many of you may not have access to that. So let me just start. I have no financial disclosures of relevance to my talk today. And clinically, when you see a patient with weak zonules, phacodonesis, it's important to determine at the slit lamp the site and extent of the zonular weakness, right? So it's important to lie the patient down, especially if you do not have a UBM access, right? So if you see a patient upright, you may think that this patient's got good vision. Why is he complaining? But when you lie him down, you realize that lens is no longer in the same anatomical position because it's actually got no zonular support. Usually when a lens does something like this, more than 180 degrees of zonular dehiscence is present. Now, if you do have a UBM, you don't really need to lie the patient down to examine him because this test is done with the patient lying supine, right? So it's very, very useful. It can tell you the extent and whether the zonules are completely gone or partially gone. So you can actually tell also the location and the number of clock hours. So you have a patient here with intact zonules, and we know the anterior, equatorial, as well as posterior zonules, and you can examine for its presence. So if some of these are missing, you know it's partial zonular dehiscence. You can also detect the presence of vitreous if you're not examining the patient carefully at the slit lamp, right? And in a case like this, there are really no zonules here. What are the capsular support devices that we have available to us? We have a plain tension ring, or you have the Bonnie-Henderson modification where you don't get trapping of the cortex after its insertion. You have modified tension rings for suturing. You have a 1-point fixation or you have 2-point fixation. And then you have these add-ons that are very, very useful that I use all the time, especially the capsular tension segment. You can add 1 or you can add 2. And recently, to add to our armamentarium, we have got the Susan Jacob paperclip capsule stabilizer for a glued capsular hook. And then we have the RC anchor. So how do you decide what devices you need? Really depends on the extent of zonulitis, the strength of the remaining zonules, whether this is a static or a progressive disease. And generally you go by 4 clock hours, all right? So if you have 4 clock hours missing, then you can just insert a CTR. If you're between 4 to 8 clock hours of loss, then you basically need 1 point of fixation. And you have more than 8 clock hours, definitely you need 2 points of fixation. And what devices you choose really depends on what's available to you and what you're comfortable with. And sometimes it also depends on the particular case, what is convenient to use. So what is important is knowing what's the difference between iris hooks and capsular hooks because we use them for different purposes. So in the case of iris hook, or a capsular hook, both do provide some suspension of the capsule in the anatomical position. They center the back, but iris hooks, unlike capsular hooks, they do not support the equator of the capsular bag, but they do provide capsular traction when you're doing a capsulorhexis like this. So this is definitely better to use a hook than a capsular hook, an iris hook than a capsular hook. And you can also use this to invert your hook and support a capsular tension segment eyelet. So for example, if you have no access to a capsular bag hook, you can actually use a capsular tension segment, which you suture in later, but you can use it in the time of phaco to just support the equator at this area. Suture material, generally we propose the use of stronger material than 10O proline, so we use 9O, or what I use routinely today is actually 7O Gore-Tex. It's CV8, although it's 7O Gore-Tex. It's off-label use for scleral fixation, and it's got excellent longevity. So I know I've presented many times the use of my suture snare technique, and I know many of you are very confused because you see so many sutures running around. So I thought, well, if I just showed you this bare capsular tension ring, this modified with a 1-point fixation, the Sione ring, and you have a Gore-Tex or a Polyene suture already preloaded onto this. Now, if you think of how you're going to get it to your scleral fixation point, what would you do, right? So this is just to introduce to you the concept of a lasso. So I thought, well, if I had a suture here that I could thread through the end, I could just lasso it and I could pull it back out at the scleral fixation point. So if you put the eye in place there, right, this comes into the scleral fixation point, and if I were to pull it, basically, I will be able to retrieve the suture here. So it's really a very, very simple concept, and you can look up this paper. So this is a case, a dense cataract pseudo-exfoliation syndrome, and I'm just looking around. It said actually zonules were intact, although weak. You know, these are the most difficult cases. They're small pupil, and you can see, well, the zonules may look like they're there. You can see the pseudo-exfoliation material. But really, you know, they give way during your surgery, especially when you have a dense cataract like this. So the shallow, I had a very shallow anterior chamber. I decided to just put a hook to provide the counterforce, and I'm using an iris hook here. Right, it's a very black cataract. I did not want to use vision blue. It won't help me that much in providing contrast, but in addition, I didn't want the dye to stain the vitreous. All right, so I'm providing the counterforce as I go along. So now I've completed the rexis. And I've very important step, putting viscoelastic just under the capsule to create space for the insertion of a capsule tension ring, a plain ring, right, just under the capsule, clean dissection of the capsule away from the cortex. And now I know my equator is expanded. In addition, I'm providing more support by these hooks that support the equator and very short vertical trench. I impale. I like to do horizontal chop. Right? It can be a bit tricky if you don't know where the equator was. And that was the reason why at the start of this case, I used the Coughlin hook to look at the equator. And at the end of that, before you come out, important to maintain the anterior chamber and then insert the IOL. And you will see that I had no cortex that was trapped. Now, if you have very weak zonules, it doesn't matter. You just mark anywhere 180 degrees apart. And then a Hoffman pocket, and now I insert a preloaded capsule tension segment. This is a cortex suture segment, and I'm just positioning it there in place. Now, very important, I've already pre-threaded this needle, which is a 27 gauge I used today. All right, I'm pulling out this lasso that we showed, putting the end of the suture through and pulling it out, like what I showed you with the lasso. Right, create this space when your needle comes through. You don't want to puncture that bag that you had been so careful in preserving, right? So this is the lasso. I'm going to repeat it exactly the same on the other side. I find the use of the MSC faucets very, very useful to help me in positioning rather than Sinski hooks where the segment can spin around, right? So make sure that when you come through, you don't puncture anything, and that is done by putting viscoelastic so that you create a space between the iris and the bag. So this is the lasso coming out through the main incision here and pulling my suture out now from the Hoffman pocket. It's important that the pocket's dissected deeply enough because you do not want exposure, erosion and exposure of this cortex suture. It will cause a granuloma that you have to go back and patch or exchange for a different material or suture. All right, so the tension is also important to ensure your RL is well centered. Okay, so let me show you the next case now. I have 3 cases, so this is my second case. So now we have another complex case. You can see everything is shaking and it's white and intermittent. So it's very nice that we had all these talks that went before, right? Fortunately, it's important, perhaps a pearl for you, when you don't have a zonular attachment, actually there is very little tension on the anterior capsule. So there's less risk of this running out. But I'm now providing the counterforce, which if I didn't, because there are no zonules here, it would run out, all right? So I then complete the rexis of the appropriate size, and you can see the shape is a little collapsed. I again inject the viscoelastic. In fact, every case, whether it's white or black, it's the same technique, right? Inject the viscoelastic, creating the clean plane. Don't be happy until you have the clean plane. And then inject the CTR. Okay, now I know my equator is kept expanded. I put in the capsule hooks that provide further support, and then you can crack right through. All right, it's a little leathery, although this is white on the surface. And you can try to minimize your rotation, and this is how I like to take it out. And you see that in all the surgeries that I do with this, I do it in a very similar manner. Chopping, sometimes you can't rotate. You impale to rotate the nucleus, all right? You swivel the nucleus around, and you can see, actually, I don't have a red reflex, and that's because I had stained the capsule. And now I notice that this has slipped off in my attempts to crack. Now this, I'm going to show you a little complication. Because I had done all my cracking movements, that hook had slipped off, a little vitreous strand came forward. And you can see I got no good red reflex there. And I think I'm getting fluid misdirection because the hook had come out, I had not noticed. So I put the IOL in first before completing my surgery. And I'm going to show you Sergio Canarava's technique of using Prolene. And this is 6O. I've pre-threaded it. Nowadays, I don't thread it on the needle. I actually thread it through the needle as it comes in the eye. But this is just to show you with the capsule tension segment. The flange has been created, and I'm then positioning it. So this is 1.75 mm posteriorly. I pull out this 6O Prolene. I thread it through the capsule tension segment, make sure it's large enough so it doesn't slip through. And I'm not very happy here because I had some vitreous coming through just now. And so I'm then doing the vitrectomy here, right? Both behind as well as amputating one that come in front. And at this time, then I insert the capsule tension segment and apply the traction. And it's important that you apply the traction first before you decide on what length, usually about 3 mm length for the diathermy. And then make sure that this is really covered by conch nicely. And at the end, you can insert some triamcinolone and then remove any residual vitreous. This is the final case I'm going to show you. It's a difficult case. You can see less than 180 degrees of zonulysis. We start with vitrectomy because there's vitreous line in front of this lens that is dipping posteriorly. Right? You want to remove adequate but not too much because it does support the lens. This vitreous behind does support the lens. And with the 27 gauge needle bringing this lens forwards, I then catch it at where the capsule was slit. And with a bimanual technique, right, you want to use forceps that are not sharp. Okay, so I started with the capsule rexis forceps. I then continue with 2 MST micrograspers. And as you go along, you can start to support the capsule, the whole lens at the capsule rexis. And at this stage, it's okay to insert this capsule back hooks. And I then switch everything to capsule back hooks so that the equator is now supported. Dissect that plane between the anterior capsule and the lens, and then insert a plain CTR. Hydrodissection, this is much softer cataract. Okay, so we're doing a stop and chop here, cracking right to the base, and then cross-chopping. Okay, so that we don't really have to do any rotation. Tumbling out the first piece, the next piece. All right, you can just tumble all these pieces out. And because the dissection was adequate with the viscoelastic, the CTR does not trap your cortex. Insert the IOL into the capsular bag, showing you again the suture snare. You can use a 26 or 27 gauge needle with a short segment of the cortex suture, creating Hoffman pocket. In this case, I was actually going to put in a toric IOL here. And you can then introduce the suture snare, 1.7 mm posterior to the limbus, and then bring the end of the suture loaded on the capsule tension segment through to the spiral fixation point. We repeat this. So now both sutures are there, and we repeat it for this other segment. So if you watch these three, they're all very, very similar, just that, we had different extents of zonular weakness, different densities of cataract, one white, one black, one dipping into the vitreous, but really they are all the same. Okay, so you can see in this case, I just use two tension segments and CTR. This really makes it easy because if you had a Stioni 1L, you would have to keep rotating the eyelid to the right place. Okay, here you can insert the capsule tension segments without rotation, no torque, no stress on the rectus even. And even if you had a slight tear, you can still use. Okay, so this is just to show you the end of this section. So these are my pearls I leave with you. If your lens is anteriorly subluxated and patients present you with high pressure, right, I always run IV mannitol. For white cataracts, I always run pre-op IV mannitol. This will shrink the vitreous as well as the lens, all right, and very often will save vitreous presentation and deepen the anterior chamber for you, right? You need to be very careful when you use trypan blue, as I showed you the second case with the white cataract. The vision blue actually went to the back and stained the vitreous. It makes you lose that good red reflex. It helps you in the surgery. If you see vitreous in the anterior chamber, you must always deal with that first by manual CCC when there is actually weakness. That's very severe, like what I showed you in the third case. Use capsule back hooks because they support the equator. All right, iris hooks, as I showed you, can actually help you in your capsule rexus, support a capsule tension segment when you don't have capsule back hooks. Delay the placement of a CTR in general, but in cases like what I showed you where there's severe zonulisis, I like to place it first because it expands the equator, and when you hook the bag up, basically you close off the space between the anterior chamber and the posterior chamber, so you don't get fluid misdirection and you don't get vitreous presentation. You inject the OVD just below the anterior capsule and the CTR in the space. This is very important so that you don't trap cortex. And in all three cases I showed you, no cortex was trapped. All right, this is the key, right? I was asked not to show you femtosecond laser, although I do this quite commonly in these cases where the pupil dilates well, and really with the lens fragmentation, you have dense cataract. These really help to make the case so much easier. Thank you very much.
Thank you.